Welcome everybody for the second session of one of the second sessions of our in-person event and the second session of our online event. Thanks for coming, and thanks to everybody that's joined us online. You're not going to see more of me again, you'll be pleased to know, but I am going to introduce our panel for this session, which is asking the question, well, the way we posed it, but you may discuss it in a different way, and I know Anne-Marie's got ideas about this, and I'm going to leave it to her. But the question we posed was, what can we learn from the history of district nursing in Britain that can guide us about the future of community services in Britain? So how the wonderful panel that we've assembled to address that question and go about it is completely up to them. I just want to introduce them briefly. I'm really, really happy to have with us Anne-Marie Rafferty, who is a very eminent historian of nursing at King's College London, as well as being a nurse herself and the immediate past president of the Royal College of Nursing. Thank you for being with us today, Anne-Marie, and for agreeing to facilitate this session. Then we have my colleague and friend Jos de Blok, the founder of Buurtzorg Netherlands. You will, and I know that this question is quite significant to your own thinking about when you founded Buurtzorg back 15 years ago, so I won't go on, I'll leave that to you. Next to Jos is my friend Jenny Rathbone, who is, as well as being a member of the Welsh Assembly, the great-granddaughter of William Rathbone, who is, I think, properly credited with being a founder of the district nursing in Britain. And Jenny will be talking not only from that historical perspective, but also from the experience of some work that we've supported in Wales, and her own experience as a local councillor, once in the London Borough of Islington, and now as a member of the Welsh Assembly, as I say. Last, but very much not least, is Helen Martin, who is the Director of Nursing, have I correctly? Yes, the Director of Nursing in Medway Community Health. We're delighted to be working with Medway Community Health, supporting the changes that they're making, inspired by Buurtzorg, and as part of a program supported by the European Union called Transforming, remember the European Union? Called Transforming Integrated Care in the Community. And we're really delighted with what we're learning together in the work that we're doing with Medway Community Health. So that's all I'm going to say. I'm going to hand over to Anne-Marie. Thanks very much.
Thank you so much, Brendan, and a warm welcome to all of you, and thank you for coming to this very exciting conference. I'm also delighted that it's in this venue because I can just feel the electricity in the room, and Mr. Faraday is looking after us very well as we come in the front door. So our task today is to share and discuss and discover what there might be to learn from the British tradition of community and district nursing that might apply to other domains and models of community, district and neighbourhood nursing, and indeed how those models are being adapted and implemented in different types of environment. So I'm going to ask each of the speakers if they would like to kind of give a pen portrait of their perception and response to the question, how can the history of British district nursing guide us to a better future? And we might also ask the question, can history guide us at all? So taking a little step back from that very important question. And I'd like to start with asking Jenny if she would kick us off by saying a few words about who she is, how she interprets her role, and just her initial response to this. And the reason I'm starting with Jenny is, as you heard from Brendan, she is also the kind of custodian of that family tradition, the Rathbone, and we are in the presence, I dare say, of community nursing royalty as a consequence of that. So no pressure, Jenny, but the origin story, how does it feel and how does it look from where you're positioned now in the 21st century?
Thank you very much. Just a little bit about me. I'm a member of the Welsh Parliament, otherwise known as the Senedd. I represent Cardiff Central, which is a very diverse constituency with with the poorest wards as well as the richest wards. So a bit like London, people live cheek by jowl, and it's also a very multicultural area, so not particularly representative of the wider Wales. Before I became a member of the Senedd 10 years ago, I managed a Sure Start programme, probably the most significant thing I've done in my life, which was the most important innovation of the Labour government. I also used to chair independent reviews of NHS complaints, which tended to be about when things had gone badly wrong and somebody had died, and the outcome was being contested. And I also used to chair a maternity services liaison committee in my spare time, which involved 3 different teaching hospitals, and there were some very interesting conversations there. So my great-grandfather, William Rathbone, undoubtedly founded district nursing. I'll have words afterwards with Brendan. Basically, he built on his own personal experience. He had a personal tragedy in his life. His young wife was dying, and he was a wealthy man, so he obviously wanted to buy the best for her, and he engaged the services of a nurse to look after her because she had what was called consumption, which was presumably TB. In those days, you died of it. Mary Robinson was the pioneer of district nursing, because after she died, he was a very reflective man, and he was also framed by both his family history and also his religion, which wasn't about proselytizing, it was about trying to make for a better society. So he asked this nurse to do a 3-month stint working in one of the poorest communities in Liverpool, which is where he lived. And after a month, she pleaded with him to let her stop doing it, because she said that the distress she was seeing was so great. But he persuaded her to stay on and do the full 3 months she'd signed up for, at the end of which he said if he kept her on, she would never go back to any other kind of nursing, because the impact of her work was greater than he had predicted. The cleanliness, the decent food, and the fresh air that saved lives, and people with chronic illnesses were restored to health. And if you think about that, that is very similar to some of the challenges we face today. So having been successful with this pilot, he was a really energetic guy, so he decided he was going to obviously mainstream it, but in order to do that, he needed to find more trained nurses. But there weren't any, because nobody was training nurses virtually. There were 2 hospitals in London who were starting to train nurses to work in the hospitals. But mainly, people who were badged as nurses were basically people who were recruited from the workhouse to sort of work for their living, if you like. And they brought with them all sorts of habits and lack of understanding of the importance of what a trained nurse would know about. He basically asked Florence Nightingale, who'd made her name in the Crimean War, which was when more people died of disease than they did in all the battles. So she said, well, you'll just have to set one up yourself. So he did, because he could, because he was a wealthy businessman. He knew what things cost, and he knew how to supervise things. And he persuaded the Royal Infirmary that they really did need some trained nurses, and that they would attach the training school to the Royal Infirmary, and they would get first dibs on these trained nurses. And then secondly, the women would go and work in the community in the way that Mary Robinson had done. And so within 6 years, the whole of Liverpool was covered by district nursing. divided into 18 districts, and each district had a trained nurse in charge and a wealthy woman or group of women who were responsible for paying her wages and providing the food and medicine she needed to do her job. Because you'll remember that there was no NHS, and the poor basically just died. Nobody went to hospital. That was for the wealthy people. So, and William Rathbone really thought it was important to understand exactly what he was doing and what he was investing in. So he used to go out and sit in the corner of the room and had a really clear idea of the conditions in which people lived. And he put a great emphasis on inspection to ensure that standards were maintained. So initially he thought that was the role of these lady superintendents, but latterly he thought maybe they needed to be trained nurses who had superior qualifications. But I think one of the quotes I would like to just end on is, above all, the nurse's business was to do whatever would relieve the suffering of their patients and help to cure them, and should never be allowed to refuse any service necessary to this end, however menial, on the grounds it was not part of a nurse's work. So that's him really, and he then went on to become a member of Parliament. And then, of course, the QNI was set up in London, which is strains of, the over-centralised governance we have. Why was it not set up in Liverpool when he'd pioneered it up there, shown it worked, and that is where they should have established the QNI, but they didn't. So, thank you.
Road's not taken. Thank you so much, Jenny. That's really excellent. I think gets us off to a tremendous start. And given that backdrop, therefore, I'd like to invite Jos to really talk a little bit about his inspiration from the British model and how he has adapted that to the environment of the Netherlands. Jos.
I'm not sure if I did, but no, I was always, my background is a nurse. I became a nurse when I was 21. And I was interested in systems. And I learned about the NHS when I worked as a community nurse. And I saw at that moment in Holland, it was in the 80s, that there were a lot of similarities. So the primary healthcare system was, I think, a bit similar than what I experienced from the UK. And I think it was at the end of the 90s, I had a district nurse from England doing practice in Holland. So then I learned on one hand there were similarities, but on the other hand we also had the same problems. Because at that moment the work of the district nurse was getting under pressure. And in Holland at that moment also the profession of community nursing was almost disappearing. So in policy notes from the government, they didn't speak anymore about community nursing. It was just about delivering tasks and activities and products, and it was all industrialized. So the similarities for me led in, I think in 2001, that I did a project in Ukraine. So another interesting country, where the costs of the healthcare system were so high because everything was hospitalized. So everybody went to hospital, and based on a project supported by the European Union to get Ukraine part of the European Union, it was I got the opportunity to work for 4 years in developing primary healthcare in Ukraine. And then I thought all these principles from the systems I think were working well in the past were similar. So, and I tried to implement it in Ukraine, and it became a big success in Ukraine because the consequences were that the quality went up and the costs went down. So that was a simple thing, and then the university started to train GPs, and the school started to train community nurses. And after that, I thought I looked at the World Health Organization in 2000, 5, the main vision of the World Health Organization was that community nursing should be the future. So if you look at it now, you see in a lot of countries the discussion about dehospitalization. And then if you look back, these principles, which has a long, I think, history, are becoming more and more important again. So connecting with the community, trying to do the things which creates healthy communities. And that's something completely different than delivering activities. So we went from a kind of management idea, we went to delivering activities, and I think we have to get rid of this thinking, and we have to get into the new paradigm that by connecting people in neighborhoods and using our profession in another way, by creating solutions in a way that we are not needed anymore, so that's and have the space and autonomy for that. But I think it's based on the old principles of the 70s and perhaps long time before that. But that's how I experience it, and what we see now in the 30 countries we're working with, the problems are similar. I was a few weeks ago in Denmark, and then you see this search for getting rid of the new public management. If you say that in Denmark, then everybody gives applause. That is kind of a disease. And now trying to get back to the authority for the healthcare professionals to do what they think they should do in a simple network. That's one of the ideas I hear in a lot of countries. So this is my reflection on when I read this. Doesn't know if it makes sense, but for me it's the inspiration lays in the past.
Thank you so much, Jos. That's wonderful to hear. As a historian, music to my ears, I'm sure many others. I think, gosh, the fact that you're in 30 different countries now is just astonishing. And this eternal quest, it seems, to get to dehospitalise and bring care, the centre of gravity of care, into the community seems to be something that we are perpetually struggling with. Mm-hmm. It'd be interesting, we can discuss the sort of historical tipping point of that in different countries. But before we get into that level of detail, I'd love to invite Helen to talk to us now about her kind of take on some of these historical issues, and also what your role is really, Helen, and what you're trying to do in your patch, in your neighbourhood. Thanks.
Thank you very much. So I have a history of community nursing that goes back over 30 years, and I moved very quickly from working in an acute hospital out into the community because I had such a great practice experience that I wanted to move out into community and work with the local population, patients, their families, and their loved ones. And I saw that was the true way that I could give holistic care as I'd been taught in all of my training. I work in the Medway Towns, which is in North Kent. That area is where I originally moved into to do community nursing, and it's where I've gravitated back throughout my career. Although I was very much grounded and working on the patch, as we know it, as a district nurse, I moved into various roles such as liaison roles and professional leads for integrated working, nurse leadership roles, and I'm very fortunate to be in the role that I am as the Director of Nursing in a community interest company. And the benefits of being in that, with that experience, with that leadership role, and being in an organisation that has a can-do attitude, it means that I can take all of the principles and all of the things that I learnt as a community nurse and take that through my career and help nurture that culture with the nurses and other professionals and staff that work within our organisation now. I think the bit for me around history and listening to both of you can very much resonate with me, because the history, my history, very much fits with that. The Community Care Act back in the early 90s was a bit, for me, as a tipping point. I came out as a staff nurse before I did my district nurse training. Some of you might be familiar with that. And when I came out to work in the community, we didn't differentiate between healthcare and social care. There wasn't that I only do these nurse duties and you do the washing and dressing. When I used to go and look after patients and patients on my caseload, we did everything for them. So we got them up, we helped them get dressed, we did whatever their nursing things were needed, but I got to know the families, I got to know their stories. I was very much treated as part of that family, and I think for me, the lessons learned is how do we recreate that culture and bring it together with all the wonderful excellence, technology and all the expertise that we've got now, and how do we bring those two things back together again.
Thank you very much indeed, Helen. That's really brings us, I think, bang up to date. And if I may just jump in with a question, I'm sure that members of the audience have got their own questions as well. I'd like to ask you in turn, because we heard this morning, and not everyone, of course, will have heard the talks about healthy communities, but it seemed from what some of our speakers were discussing that there are certain fundamental principles of practice about agency, about empowerment, about autonomy, about giving away power, or in fact taking that kind of power, that seem to be designed into what makes for healthy communities. And I just wonder whether some of those principles or active ingredients can be built into the models of practice that you've seen, either historically or indeed through your own work. What the design features, if you like, are of successful community, using that word advisedly, nursing type models. So I don't know who'd like to go first. Jos was looking at me, so maybe Jos first. We'll go along the line in that. Jos, then Jenny, then Helen.
Yeah, okay. Yeah, for me, you easily get into kind of abstract discussions, but for me, it's very practical. So first, I think you have to address what are the problems we want to solve. Mm-hmm. So, and when I looked at my career as a community nurse, it was not so difficult. You had healthcare problems and social problems, and you started to find out what you could do with that. So, and building a relationship was part of it, because if you don't know where somebody comes from, you don't know what to do. So first I thought we have to simplify this process. So between you and the patient, there has to start something, but gives you the tools to do something. So, and this process is happening all the time. So this routine is a daily routine, which is in every neighborhood, all over the world, is the same. So if you say this is a universal routine, then this should be the basic element of the design. So you have your skills, you have your knowledge, and you have the problems of the patient, and there should be a connection that you should be able to deal with. So there also should be a connection with the education level and the kind of problems. So if you don't have the right education to deal with the problems, then the solution probably also won't be very effective. So that went wrong in a lot of systems in the world, because if you focus on the activity needed, then usually you're not solving the problem. So you're only delivering the activity. So the mindset that you are focusing on the result, on the outcome, instead of the activity and the input, is quite a big shift in a lot of systems. So that also means that the payment system should change. So the payment system should reward good results instead of paying tariffs for activities. But the design should be based on a simple model where you say we have a clear vision about how people who have healthcare problems deal with their problems. So if you said people want to have an independent life and they want to have a high quality of living. That's as a simple principle that should be driving the activities of healthcare workers. So if you look at it way, then, because if you say now we have to deliver 10 activities a day for 15 minutes, then you have quite a different perception of what you're going to do. Then we say, no, I'm going to work in this community and I'm trying to find how I can create networks so that the solution for this patient is the best possible thing which I can think of. So the design should be based on this perception of this daily routine, the way you look at healthcare in general and how people deal with their own health, and how you can organize it in a way that it is a kind of a learning and dynamic environment. So we made it very static. So in my perception, when I started to work as a nurse in 1986, I was learning all the time based on what I was doing. I was working with volunteers, I was working with schools, I was together, we had discussion with the doctors about the difficult cases. And it was a learning process, and the tacit knowledge you learned all the time increased. So every few years you could say that a new generation of nurses had more ideas and tools than the older generation. So, but that stopped in 1995 in Holland because of the system changes. So then it went to products and activities, and the whole tacit knowledge and learning process disappeared. And prevention, the ideas about prevention, which had a very high standard, also disappeared because prevention was not paid for anymore. So this connection between the daily practice and the routine, which in my idea is very simple. So if you just let teams do this in a certain environment, a certain neighborhood, they will find solutions for everything, and then you only have discussions about how many people do we need, and how can we try to do it in a way that we improve all the time our services. And then on the system level, and that's I think also in many countries a difficulty, we need systems that support this process. But there are a lot of people in the system who don't have an interest in changing the system because they have the positions they have, and they also don't have the knowledge of this practical daily practice. Yeah. So I hope I took 1.5 years to design something for Holland. And my main idea was, how can I convince the inspection, the health insurance, the union, that this is a much better way to deal with the capacity of nurses and the healthcare status of people than the existing way. And the only thing what really helped was showing that it was much cheaper. That was for a lot of people, the KPMG report and the Ernst & Young reports, that shook the politicians, and then they said, it's not true that people who are 80 plus need more and more help. That's not true. That's a kind of a political perception. And if you build your system based on this perception, you're doing the wrong things. Everybody is learning till they're dying. So if you look at positive health, people are learning how to deal with their problems. And sometimes we find medical solutions for social problems. So we should find out how we can, from a holistic perspective, and that's I think also what Helen said, how we can combine and integrate activities in a way that for the coming 20 years we still have the ability to use all the capacity we have and all the capacities to serve and to create an accessible system. It's a mix of a lot of things, but I don't want to give the idea that it's very simple to create this transition. It is difficult, and the nurses who are here know that the daily practice is sometimes very simple, but the struggle in the system is something which is sometimes very difficult.
That's really enlightening, I think. Thank you so much, Jos, because you've very clearly articulated this internal contradiction between having simple principles and trying to enact them within very complex systems. Jenny, I just wondered how you respond to that, and with the sort of spirit of the Rathbones running through you, do you think this is something that, you know, your predecessors would have recognised, specifically your great-grandfather? Is this something that could have been part of that initial instauration and vision?
Well, I think I want to pick up on Jos's point about the need to focus on positive health.
Yeah.
Because in Wales, no change is not an option. We already spend over half our total budget on the health service. And we have the sickest population of all the 4 nations. And that's partly historical because people in Wales were responsible for digging out the coal and the iron and the steel, which made the Industrial Revolution, but the money didn't stay in Wales. So we have very, very poor general health. We spend over 10% of our budget on treating people with diabetes. And we do almost nothing about reversing type 2 diabetes. We're beginning to think that that's something we need to do, but we absolutely, diabetes will consume the health service if we don't completely change the conversation about the causes of all this, which is poor diet, poor housing, poor jobs, which we saw all too clearly during the COVID pandemic. The COVID is a disease of poverty, and the vast majority of people who died were people who lived in poor health, people with diabetes, with COPD. These were the people who did not survive COVID, and who also tended to be living in poorly ventilated, poorly heated homes, and were the ones who were having to go out to work because they couldn't do the job they were doing, through a computer down the line. So it's a real wake-up call for us, and we absolutely have to change, because otherwise we will continue to have the inequalities that we have, simply because we aren't paying attention to the beginning of life and the importance of what happens when somebody becomes pregnant. And everybody wants to do the right thing by their child. We don't adequately support people. We don't give them support when they want to breastfeed, and we absolutely don't give them any advice about weaning. So we just allow people to give people bottles of baby food with salt in. This is still, completely unregulated. It's quite extraordinary, really. So we currently have we've piloted neighbourhood nursing in 3 different areas of Wales. One was an urban area of Newport, and the secondly in a valleys community with these informal industrial communities, and the third was in a rural community. And that is now going to be rolled out across Wales. But we clearly have lots of major battles ahead around, are these people going to be given the autonomy to do what they think is best for the communities they're working with, or is it going to be controlled by people who are used to determining how people should work? And there are some issues where I completely sympathise with that issue of control, because many nurses have become so de-skilled that they don't know how to deal with people who need to use insulin to survive. And we've had some hairy stories, some never events where people have died. because the wrong insulin dose has been either self-administered or administered by the nurse, and their lack of knowledge about what you have to do to ensure they survive one of these critical incidents. And it's extraordinary, really, isn't it? Given that we've got at least 10% of the population with diabetes, every nurse, every doctor needs to know how to deal with it, because this is absolutely endemic. But we clearly have a major battle ahead with the food industry, with the advertising industry, with all these digital advertisers who are telling people to eat all the wrong rubbish, which contains nothing nourishing. And at the same time, we have terrible food security. We don't produce enough of our own fruit and vegetables. So these are major battles we have, and in the context of the climate emergency, we can't go on spending over half our budget on health, so we absolutely have to change.
Thank you very much, Jenny. It sounds as if we're coming to a point of reckoning. And just finally ask Helen what her reflections are and what she's heard.
From my perspective, one of the things that I think we've lost is that sense of community and who is the community that we belong to. I think that the pandemic actually demonstrated that there were pockets and communities that came together, but there were also quite a lot of people who were very isolated, and we didn't know they were there. And I think the community nurse, being at the heart of that community, has lost its way over the many years, and I think that's been influenced by all the things that just been described here around systems and money. But interestingly, when I was reading and having a bit of a refresh of my history over community nursing, I was reading, back to your to relatives, there was a sense of overwhelming of the volume of what was in front of them around, what we need to do. And I think what we need to do now is actually support our nurses to work in the small scale of something that they can achieve and achieve with their communities. Try and take away some of those pressures that are around the politics or the money or the inspection regimes, etc. Try and protect them so that actually they can do what they went to do their training for, what they're good at doing, that they can get their confidence back again. And certainly within Medway and what we're doing with our rollout of our neighbourhood nurses is to empower them to be back in their community, try and deflect some of those things away from them that actually detract them from providing the nursing that they wanted to do. That's a real struggle. It's a struggle for me even in my role as a director. It's a struggle as part of a system because you're trying to deal with these challenges all the time. We can't do it within our organisation unless our whole organisation is signed up to it and understands what we're trying to achieve. I think you can have a team that works in their community and they can do a great job, but actually we need to give them a voice as well within our organisation and within our system. So for me, it's about refinding our community. Who is it that we need to be part of? Help deflecting some of the things that the nurses don't need to be involved in. And I think the other interesting bit to note is around that whole health promotion and health prevention. I look back at one of my old job descriptions and health promotion was very much key part of my job description. I think it's an add-on now, or it's done by other people. When you're actually working with a family and you're in their home and you're getting to know everything about them, you know everything. I remember knowing what was in the fridge of my patients, not because I was nosy and sneaking around the house, but actually I would be going and making them a cup of tea, I'd be taking the milk out, I'd be looking in the fridge, I'd be talking to them, I'd be observing them, and we're missing some of those opportunities now to work much more closely with our local populations.
Thank you so much, Helen. So some kind of salutary tales there, but also some glimmers of hope. And I'd like to open up the questions to the audience. And spoons and mics can be shaken and gestured at, or, well, you could start playing the spoons if you like, if you're that way inclined. So any questions? What occurs, as they say? We've got a question in the front here. Great.
My name is Yasmin.
Yasmin, brilliant.
Thank you for the history, and thank you for having Jos and Helen here today. It just brought everything together. But what I would like to say is that, Jos has explained about the system change. System changes process. I think that's a fundamental aspect of what we're discussing here. We've got an example in Holland. The history is similar. So we could learn from them. And I think as politicians, it starts from the top, because we need those system changes to help to bring this, I think Jos also explained, simple design models. Mm-hmm. I think that will help. So as a politician, if I could ask Jenny, how we could learn from these examples to help things forward, because it's not only about discussing these things, it's about learning from the experiences that's in other places. We want to adapt this model, but how do we go forward? We're here, we're discussing this, so that's my question to Jenny. Thank you.
Thanks, Yasmin. Jenny, do you want to, since very directly aimed at you?
I mean, we do have a different system. In this country, we have our National Health Service, and we need to treasure that. So we don't have the sort of health insurance system that you have in Holland. Mm-hmm. So we are going to have to do battle with the people who control our health service if we want to change. I'm afraid there is no other way about it. We're going to have to assert the need to change. And we have to ensure that our grassroots healthcare workers have this parity of respect with people who regard themselves as superior. The consultant who doesn't think what the nurse has to say is important. This is a battle we have all the time. The consultants who refuse to devolve services to where people want them, which is in the community. They don't want to go to hospital. They may need to go to hospital. If they need to have a triple bypass, they're going to have to go to hospital, or if they break their leg. But there are many services that need to be nearer to where people are. And I'm glad to say that our health minister is fully signed up to that. But it's going to take a lot of negotiation with our clinical colleagues, because I'm sure Helen would agree that it's still quite a battle to ensure that people who think they're the bee's knees are no more than part of a team, and that everybody has a role to play, and we simply aren't going to have neonatal units on every street corner. There's a place for them, but they shouldn't be driving the overall agenda.
That raises the question nicely, I think, of place-based care. And while you're thinking of another question, I'd just like to ask something that's popped up online. And this is from Natasha. Natasha's asking, to what extent does the funding coming into health and social care enable or disable innovative ways of working? So that's a rich question. And perhaps Helen might take first punt at that one.
One of the, just coming back to your previous point and that online, it's really hard work collaborating and championing something, and you can get very fatigued with doing that because you feel you're constantly battling. for me, within our local area, and focusing on that place-based and the change that needs to happen, it's around constantly championing the cause with our commissioning colleagues, with our chief executives of our acute hospitals, our local primary care networks, GPs. It's about how you influence them with the ways of working that you think are going to make a big difference. And I think it's we have a better chance of doing that on the ground, and we have a better chance of looking at shared and pooled funding at that level to make a difference. So we're very fortunate within Medway that we work with a unitary authority. We have funds like the Better Care Fund, and we have a local authority that's prepared to look at that shared funding for the greater good. And discharging from hospital is a good example of that at the moment, of where we know we're under considerable pressure. Is that where we can put that money and make a difference? So for me, it's about embracing place-based change, working with our local authorities, with our commissioners, as we certainly move into a very different system, and using the funds for that local area. But it does take a lot of collaboration, a lot of championing, a lot of battling.
Sounds like, again, it's Professor Faraday and energy that's needed, and a lot of it to keep going and hitting all these kind of targets. Jos, have you got any reflections on that point, having
Yes, I have.
rolled out your model?
Yes, I think we need a disruptive model. So, so in system which can be improved, you should not improve. So we are improving things which are based on the wrong fundament. So and then if you keep on building on that fundament, then it's becoming more and more complex. It's becoming more and more difficult to change it. So some might is that we have to say at this moment that the principles, for example, if you look at the principles of the NHS, I think that the structure of the NHS doesn't serve the principles anymore. So that's what I see from a distance. So and some people dare to say it, and some people said no, we can't say it because we are so proud of the NHS, and we have to keep it as it is. And I think this is happening in a lot of countries. So it's not special about the NHS. But I was impressed by the Danish Minister of Health, who said we need to change the Danish healthcare system, which is also one of the best in the world, I think, if we want to create a sustainable model for the future. So it's not about now and it's not about the past. It's about what are we going to do the coming 20 years with all the vulnerable people we have. What are we going to do about the diabetes? It shouldn't be possible, in my opinion. We have so much money in the system, but we are using it in the wrong way. And so if you say we want a patient-centered, person-centered, community-centered model, then you should build on that. So you should ask yourself what is not contributing to this patient and community-centered way of working. And you should take away everything that's not contributing. So, and if you look at from a system perspective, in my opinion, 20 to 30% what is in the system is not contributing. It creates bureaucracy. It takes away time from people to spend on what they should do. And if you don't address this politically, then nothing will change. Then we will go on creating the same problems that we are doing for 10 years, 20 years now. So we need to create a perspective, and for this perspective, I think we need a very clear but simple vision. So the start this morning was wonderful to hear about how self-organized communities can work. And this based on simple principles. So I think we should not cover it up and say, okay, just move on and improve and let's try this and let's try that. I've been in England now for 11 years. The first meeting I had was with a dinner was organized by KPMG. So it was connected with the conference the next day, and there was a dinner, and there was somebody from the House of Lords. I forgot his name, but he was 73, 74. And he was saying, what happened in Holland is perhaps possible there, but this is not possible with the British nurses. They don't know how to do it. This is what this man said. And he said, this is exactly the problem. Mm-hmm. Because if this is the perception, if you don't trust your own nurses and that they know what to do, that is creating the system we have. Yeah. So there are too many people who don't really know what the daily practice is in the communities, and the political discussions, in my opinion, and this is what I see in a lot of countries, are far away from the daily practice. So I should say dismantle the whole idea, keep the principles alive. The NHS principles are wonderful. They should be an example for the whole world. But the organization where it went to in all those years is not supporting them anymore. So that's from an outsider looking in.
That sounds like a really radical challenge in the dismantling and the diagnosis of what actually needs to be dismantled, removed, the obstacles taken out of the system. And that in itself is a design challenge and needs skilled people. Or maybe it just needs a sort of series of robust conversations.
And common sense.
Yeah. We're one of the, I guess, recurring themes here is we're really at risk and probably engineered to overcomplicate things. And how do we strip them down? How do we simplify them moving forward? We've got time maybe for another one question, and there's two at the back there. Let's take both of those and have a roaring kind of race towards the finishing line. Thank you. That's right, Brendan, we did, didn't we? We'll claw back our time.
Hi, good afternoon, everyone. My name's Liam. I'm a district nurse up in Durham, but I'm also a teacher at a local university, and we have DN-SBQ students who we teach. I agree with Jos, something needs to change because we have too many excellent district nurses and community nurses who are leaving to go on to other professions. Yeah, because the pace and the pressure that district nurses and community nurses are under is just immense. And picking up on something that you said as well, Helen, about health promotion, in the university, obviously, the health promotion things are within the Q&I standards and the NMC standards that we teach on the programme. So we're always incorporating that health promotion content into the teaching that we have. But a lot of the time now, when you're going out to visit 20 to 22, 22 to 24 patients per day, there just isn't the time to deliver that health promotion. We do it, but we don't do it as effectively as what we should because the pressures are just immense. So it's more of a comment, really.
Thank you, Lee. Passing on to your neighbour now.
Hello, I'm Raymond. I'm the Chief Exec of a mental health organisation that works only in the community, but increasingly with interfacing with the NHS in healthcare settings, hospitals. I just wanted to thank you for giving some historical context. And Jenny, your great-grandfather, your quote that you ended on was the basis of nursing at the time that as he saw it. And unfortunately, we've lost that completely. And that is one of the problems. And Helen's alluded to it and Jos has alluded to it. And if we went back to that kind of idea and allowed people to do what they're good at and intuitively want to do, we would ultimately get somewhere quicker. And I think there's probably over the course of time, the principles we know about the NHS really are free at the point of use. But to name all of the other principles which may be around is going to be a more difficult thing as we go forward, and we need to redefine it. So part of my role really is allowing people, which even sounds pejorative in the sense that I'm saying it, of people doing what they are good at and want to do. So my teams, I don't employ nurses, and all four of you have some sort of nursing connection or nursing background. But I think that a lot of what can be done in communities, Gregor Henderson of the Public Health for the UK said everything that's going to happen in mental health in communities, about 88% of it is going to be in communities, not hospitals. So we have to address that problem. And it's also been a failure of political leadership, but also system leadership, of which I am part. I get co-opted in to be part of the system. And sometimes when you raise your voice and you're not part of the narrative, you're seen as being an outlier. The thing I'd really like to say, the sad fact of this is Jos's point about you win the argument when you prove that things can be done better but cheaper. And if you're good with numbers, when I'm good with numbers, I do a whole presentation about how I can create a system that's much cheaper, and I call people sort of, join into that. We can win those arguments because the information is there, but we have to be really clear about where we're heading as a system. And those within us and those sitting here, we have some fantastic nurses here. I can hear conversations all day about what people would like to do. We also need to raise our voices within the system and try and take leadership for trying to make some change. So thank you for we're only 40 years away from Cecil Parkinson presented the Community Care in a Community Act, and Margaret Thatcher in 1979 said it was too radical to be presented to the British public. And in 1980 we did it, and we took lots of people out of asylums. That's only 40 years ago. So we've got a way to go, and I'm very thankful to hear the positive messages coming from the panel and also from the people in the room.
Thank you very much indeed for both of those comments. I think I feel a revolution brewing here and a real call to action. I mean, maybe if we could pick up on one point, and I know this is something that's embedded in history, and it's about skills and capabilities. Florence Nightingale referred to district nursing as the Star of Bethlehem. How can we make it the Star of Bethlehem? Where she insisted that those nurses had to be really well educated, better educated, she considered, than nurses in the hospital because of the complex composition of skills that they actually needed to be good at what they were actually doing, and to know that and to feel they're in their kind of slipstream of stellar activity and doing things in the flow. So I guess my kind of question is, taking some of what you've said, is, how do we make community nursing the career kind of choice of some of the most talented leaders that we have within the profession, and to somehow revivify and reinvigorate community nursing with the energy that was a Freudian slip, wasn't it? Getting rid of the enemies that it actually needs to move forward. Any reflections on that from our esteemed audience? Helen, thank you.
We have an opportunity, end of the pandemic, or coming out of the pandemic. We know that we've got very exhausted but still very dedicated nurses. We've got an opportunity to raise the voice of community teams, and we also have, I think, a responsibility to make them at the heart of the place-based care that's proposed going forward.
Thank you very much indeed, Helen. Any other reflections?
A lot of people argue that the NHS is underfunded and has been for the last 10 years. And I'm not quite sure whether I agree with that. But the point is that the UK government, if they don't provide more money for the health service, then we're simply going to have to do things differently, because it's the no change is not an option. And that does mean going back to the basics and empowering teams in the community to work with the community, to do what's best for them. And I suppose one of the top priorities for me is if we've got decent community teams, then we're not sending people off to hospital to die. Nobody wants to go to hospital to die. And it's about the risk-averse doctors, normally, who don't want to be responsible for somebody who's clearly in need of nursing care, but who's not best placed in a busy hospital. I think, yes, it's much cheaper, but I also think it's what people want. Who wants to die in a hospital? Not me. I think we can use the mantra of co-production to ensure that we get more of what people want as opposed to what clinicians say they need. And I think that has to be the way forward. We over-medicalise a lot of the problems we have. And that's not what people wanted. They want to be heard, and they want somebody to give them some advice on how to improve their well-being.
Great. Thank you so much, Jenny. That's excellent. Jos, the final word?
Yeah, I'm very optimistic because everything what needs to happen is already happening. So there are wonderful examples, like you just said, in the mental care. We need examples. What Helen and Martin Raleigh are doing with Medway, I think is a big step. What happened in London with the hospital, Guy's and St Thomas. Yeah. These examples, and the nurses understand this. This is possible, and as long as we have people who stand up and tell it at the right places, and we have more and more politicians who say, okay, it can be done differently. I don't think it's about the money, but it's about how to deal with the money and how we get it to the right places. So I'm very optimistic that the coming 10 years there will be more and more examples and more people who understand that we need another direction, and we will have very happy nurses and happy patients in the future.
Well, thank you so much. It does sound as if we are reaching that tipping point historically, and I'm going to hold you all to your predictions as a historian in 10 years' time, if we're all here, and just see which elements of that vision have actually come true, and let's hope that it sincerely does. I just want to thank all of our wonderful speakers on your behalf, Helen, Jenny, Jos. I also want to thank Brendan for introducing us. I want to thank you, the audience, for your questions, and of course, questions from the audience online. Thank you so much for an absolutely riveting and revolutionary moment in the history of community nursing. Thank you.